All right, so the rules of CTO PCI are simple and straightforward. Dual in angiography, use of microcatheters, procedural planning. But I think that as we work through the complexity of these cases, really we realize that the simple cases, the antegrade wire escalation, the 5 millimeter short occlusion is something that generally is approachable with basic CTO techniques. And then as you graduate up the slide, and this is a slide stolen from Lorenzo Lazzolini's paper, you get to retrograde epicardial cases where the risks are a bit higher from that standpoint, going back to Elias's slide, looking at the risks of these interventions. And the tools that we need to accomplish these tasks are different. This isn't just a CTO talk. Complex coronary intervention isn't just chronic total occlusion. It incorporates complex imaging, physiology, and the management of coronary disease for these patients who have frailty or depressed ejection fraction. But just like you wouldn't play golf with a putter and a driver, you really want all 14 clubs in the bag. You want to have the right tools available for yourself as well. So the turnpike catheters we use quite frequently for intervention in complex coronary disease. So this is the construction of a turnpike catheter as an example of a microcatheter. So there is a wire lumen, which is slippery, made out of plastic and braided. Outside of that braid, you have coils, which can be unidirectional or bidirectional. So here there's 2 directions so that you can torque the catheter in either direction, storing up that torque and transmitting it to the distal microcatheter. And over that is a hydrophilic polymer jacketed outer layer so that this is slippery. And the goal when we're using the majority of these catheters, the torqueable microcatheters, is to reduce friction. So we spin them frequently at a high rate in order to reduce that friction as we move through the vessel. So looking at the Turnpike family of microcatheters from Vascular Solutions and now Teleflex, they have a group of microcatheters that solve the issues for antegrade, for retrograde, for calcium, etc. We'll go through some cases with regards to how we select the use of microcatheters, and we welcome questions at the end on specific microcatheter selection for different scenarios that we're going to go over, or other scenarios that you guys may have encountered in your clinical practice. So a case. So this is a 56-year-old guy who had a non-STEMI, had a circumflex PCI, and just like 20% of patients who come to the cath lab was noted to have a CTO as well of the right coronary. Never felt great after his circumflex PCI, so he came in for evaluation. He was on 3 antianginals with a great blood pressure. Stress testing showed inferior scar with an peri-infarct ischemia, and the entire inferior wall was viable on MRI. So he came in for CTO PCI, and the plan was to go biradial, which is, as Elias said, about 75-80% of our cases now, unless we had prior failure or need for an 8 French system. And you can see here that there are interventional collaterals from the AD. And the proximal cap was just a bit ambiguous, but I was trained to, and I still do to this day, usually start antegrade and then flip retrograde if we get subintimal and can't rescue that with ADR. And sometimes it works just well. We were able to get started without really any issue in an antegrade fashion. Retrograde injection we perform in order to make sure that we're headed the right direction. At some point during most of these cases, antegrade injection through the antegrade guide, in this case the 3D right, is not recommended. You've created a dissection flap, you're extra plaque in a lot of the cases that you're doing, and injecting antegrade can tear the vessel and end the case prematurely. It's always important, though, to check in multiple views that you're actually headed in the right direction, because in a single projection, you can be in the right plane, but when you go RAO from an LAO or vice versa, you find that you're off in a small side branch or the middle of nowhere. Usually not an issue if it's just the wire. If you follow with a microcatheter out of the vessel, that becomes much more of a problem, and it makes the day just go a lot worse from that standpoint. So here we were good in the RAO projection. So advanced our torqueable microcatheter into the extra plaque segment to allow for more purchase and push. And then it popped into the RV marginal on retrograde injection, which was distal to the distal cap of the CTO. So we knew we were good at that point. We have a couple of options here. We can go in with a dual lumen microcatheter, own the RV marginal, and use that to then wire the distal RCA, or we can pull the wire back, parallel wire, etc. In this instance, the wire performance was such that we felt confident that we could pull back and hopefully enter the distal RCA. So pulled back and tried to re-enter into the distal vessel, and it was done in an antegrade fashion. So sometimes even cases that may not set up on the algorithm to be antegrade first, you can succeed, especially with modern wires and microcatheters. Spun the turnpike forward, exchanged for a wiggle, ballooned the CTO segment with a 2040, performed intravascular ultrasound. We're at 99.9% imaging for these cases. We think that it does make a difference for patients, and you would be surprised. You image a vessel that's a 2.5 after opening it, and it becomes a 3.5, sometimes even bigger after you restore antegrade flow. We mark the proximal and distal edges of the CTO segment. We stent, we optimize, and make sure that we meet the ultimate criteria outside the scope of this talk for these stents. In Europe, they have the luxury of bringing these patients 6 to 8 weeks later. In the US, we don't have that option, unfortunately, so do the best job you can at that time, keeping in mind Elias's maxium, perfect is the enemy of good at times. We don't want to induce complications. And we had good flow into the RV marginal. Patients can get pretty sick if you knock off the flow to their RV and having RV shock physiology. So that's that case, an antegrade wire case. This next case is something a little bit different. Again, you'll see that we're biradial, 48-year-old guy. A lot of young patients, unfortunately, come to see us and had a history of bypass with a failed vein to the right, a patent vein to an RPL, and a CTO of the distal right. So this case, it looked like we had an antegrade channel. So we set up antegrade, went to move forward, and noted, though, that there was a septal arcade if we needed to go retrograde in this case. So advanced a turnpike spiral and a series of wires in our wire escalation pathway. We can talk about that in the Q&A if people want, but never could convincingly enter the distal true lumen on retrograde injection in multiple projections. So you'll see the wire in some potentially small vessel to potentially true lumen, but again, back to the CTO guiding principle of don't follow with microcatheters unless you're sure your wire is in the architecture of the vessel in a good spot. We don't want to cause complications and make the patient worse for a procedure that's truly elective and really just to improve outcomes. So our distal wire wasn't in a great spot, or we weren't sure that it was, so we decided to go retrograde. So wired a septal with a workhorse, put a turnpike LP into the septal, started surfing, weren't getting great results immediately, so performed a tip injection to figure out whether or not we connected with distal vessels. Usually we're doing this through the microcatheter in those situations where surfing or blindly going with usually a Xi'an black down the septal trying to make the quantum event happen of connecting. This will help us give that definition to determine if we're in a spot that we can move forward. Eventually, we were able to get the hydrophilic jacketed non-tapered wire through the collaterals into the distal true lumen. And then, as Elias showed earlier, wiring the antegrade trap liner, followed by advancing the microcatheter, exchanging for a 350 centimeter wire. And then you've got a system that you can work over. I'm a fan of switching to an antegrade system. Sometimes that does expose you to the risk of losing the entire thing. You can also work over the 350 centimeter wire. So similarly, IVUS, balloon, stent. And here you can see that the outflow was pretty poor. Again, a negatively remodeled vessel that's pruny like your fingers in the bathtub. So hopefully over time it does grow as it starts to see blood flow. So, a little bit of a size mismatch, but the patient felt better and has been doing well. So in addition to the torqueable braided microcatheters that you spin as you use them, there are push microcatheters, which are more what they say, push or pull. And the Supercross family of microcatheters includes that, but also has the benefit of having angles. So often we'll see that there are angulated takeoffs of vessels, CTO or otherwise, and having especially the Supercross 120 for a case can mean the difference between success and failure. I would caution that the use of these microcatheters, if you don't know exactly where you're going, can be dangerous. My mentor from training, Jay Kotry, taught me that through case-based experience that he'd had previously. But as the wire exits the 120-degree microcatheter or the 90-degree microcatheter, the gram tip load of that wire is nearly infinite because you have the catheter supporting against the contralateral wall. So if you're not sure you're in the right spot and you push, especially a penetrative wire out, it will find a place to go and it may not be in a great spot. So making sure that you're using these catheters safely in order to achieve your goals is recommended. And then exchanging for a workhorse or supportive wire when you're done. So this is a case of a patient, 68 years old, history of an RCA CTO and an osteal circumflex stenosis on carvedilol and ranolazine with low blood pressures. MRI showed that his RCA was infarcted. He had circumflex ischemia that was intermediate risk, but came in with intractable symptoms, and the plan was to proceed with intervention on the proximal circumflex. But circumflexes are evil. They should all be ligated at birth, but this one wasn't, so we had to treat it. So had multiple issues with wiring the vessel, putting my workhorse wire down and having it prolapse out down the vessel, as you can see it start to do there. So again, two ways to use an angled microcatheter. One is to put it over a workhorse wire, pull the wire back and have it assume the shape, pulling back and popping into the vessel. My preference is to at least get the tip of the workhorse wire down, slide the microcatheter over it to help me engage the vessel, and then using the workhorse wire or whatever wire, then fully wire the vessel. Again, making sure that you're in the true lumen of the vessel or in the vessel architecture so that you can avoid perforation before you start pushing. And then from that point, it was exchanged for a supportive microcatheter and performed PCI. Intravascular ultrasound showed that the plaque burden was 90% in the proximal vessel. It was treated with angioplasty and PCI with an adequate final result. So push microcatheters, torqueable braided microcatheters, dual lumen microcatheters. We're blessed with multiple options in the US with regards to dual lumen microcatheters, including twin pass Sasuke and NHancer RX. The goal of these is multifold, actually, with regards to how they're utilized for parallel wiring, for owning side branches, for complex bifurcations in the hairpin technique. And we'll go through a case that shows a couple of those. So this is a 78-year-old gentleman with a history of a CTO of his circumflex. Angina was after walking 10 to 15 steps, and our parking garage is maybe 400 feet away from our office. Had to stop multiple times on the way over, despite using amlodipine, isosorbide, metoprolol, and ranolazine. He also had a cardiac MRI that showed a moderately severe area of stress-induced ischemia in the lateral wall. Interestingly, it was considered low risk based on that read, but he was having refractory symptoms on good meds. So on looking at this angiogram, looked like a relatively long segment, pretty minimal calcium, pretty straight, surprisingly, for a circumflex. So we planned an antegrade first option. There are some epicardial options if needed. So got started with turnpike and workhorse wire to make sure that we were on the proximal cap, and then started working on the antegrade wiring of the vessel. And again, once the wire gets into the occluded segment, you'll see that we're not injecting very briskly into the coronary artery because we don't want to extend any dissection flap, because we probably would be extra plaque at some point along the way, and usually we are. So the antegrade wire moves through the vessel. In the interest of time, I'll skip you watching me wire the wrong spot a couple of times. On retrograde injection, it looks like we're heading the right way. And then we switch over to a tapered hydrophilic wire into what we hoped was the distal true lumen, but that would have been in the antegrade wire section if it was. And so we're still extra plaque on the right side of the vessel, as you can see there. So a couple of options here. We can do antegrade dissection reentry, advance a Stingray catheter, performed AFE, performed LAST, but the issue there is that there is a pretty large retrograde branch right at the bifurcation that seems to be supplying some area of atrial myocardium. So wanted to own both of those. Makes it less attractive for us to do that, and then also potentially losing the AV groove more distally. So in this situation, we advanced a dual lumen microcatheter into the extra plaque segment and advanced another tapered hydrophilic wire through the side port in a parallel wire fashion, knowing that the first wire was extra plaque, so hopefully staying a little bit to the left of that. And on retrograde injections, we figured that we were in the AV groove circumflex convincingly. The issue then became, how do we own the obtuse marginal so that we don't lose it? And again, we have the luxury of having a dual lumen microcatheter available, open, and ready to go. So pulled the dual lumen microcatheter, swapped out the wire and the AV groove for something safer, and then basically used a hairpin-ish technique with a workhorse wire. You can see here that we were able to deliver it into the AV groove, pull back, and then have it flip down into the obtuse marginal here without too much issue. So now we own the AV groove, we own the obtuse marginal, and it becomes a straightforward PCI, IVUS, balloon, stent. After confirming, of course, that we're actually in the true lumen distally. So imaging as usual. And overall, a good angiographic result was obtained here. We did go back and touch up that OM that was pinched with our work. So I think that putting it all together, the things that we're doing, the main goal of it is to improve outcomes. We know that the open CTO trial showed that at 1 month, patients who followed up had an improvement in their quality of life. There are other opportunities to improve patient care, potentially with proximal LAD CTOs in patients with reduced ejection fractions, also some emerging data in the treatment of arrhythmias for patients with chronic total occlusions and what the role of CTO PCI is for them. But by and large, for a patient who comes in with symptoms despite adequate medical therapy showing ischemia and or viability in a CTO segment, we offer them this as an attempt to improve the quality of life that they experience, which again is what the patients that you're seeing here today came in with. So a 68-year-old gentleman who worked in the penal system found that he was having angina walking up and down stairs at the prison he worked at. He, as you can tell, has had multiple interventions on that right coronary artery, had a PET scan showing inferior ischemia, no scar whatsoever, had a diagnostic cath that showed an occluded right, and here you can see dual angiography. So came forward for CTO PCI of the RCA. Some recent data suggests that in-stent CTOs are some of the most complex and lowest likelihood to treat. So always get in pause, even if you have both caps inside the stent with regards to that. So using a torqueable microcatheter and a hydrophilic jacketed non-tapered wire, we were able to cross this. Cross-boss is also an option in this situation to move through. And then on retrograde injections, made sure that our distal wire was in the true lumen, advanced the microcatheter, swapped for a wiggle wire, and then performed balloon angioplasty and scoring balloons. After that was done, we had TIMI-3 flow after balloon angioplasty, but we knew that this probably was not going to give him a durable long-term result. We know that patients with 2 layers of stent have an in-stent restenosis rate at 1 year of approximately 20%. Patients who have a 3rd layer of stent added, that rate of in-stent restenosis is increased to 40%. So at our institution and several others, once patients have 2 layers of stent, we're performing balloon angioplasty, laser atherectomy, PTCA, and then referring for brachytherapy, which we perform on a different day for logistical reasons than our CTOs. So it used to be thought that brachytherapy would no longer be needed with the advent of drug-eluting stents, but we're finding, again, in large data sets that 10 to 15% of PCI done in this country is for in-stent restenosis. So brachytherapy is making a comeback. It's a treatment where we deliver radiation directly into the stents. A dose of 18 to 23 gray over the course of 4 to 6 minutes is given to an area where there is recalcitrant in-stent restenosis after we optimize the stent. And that's been shown to reduce the chances of in-stent restenosis to about 11% at 1 year, better than the 20+% of MACE that we would see for patients who got balloon angioplasty alone. Drug-coated balloons are not commercially available in the US at this point. Clinical trials are ongoing, but hopefully would provide another option for these patients. So after we completed CTO PCI, the patient returned after a month for intracoronary brachytherapy and further optimization of his stents. You can see that he's already started to restenose a bit, and intravascular imaging was performed, which showed that there were several areas of underexpanded stent. We now have a few options to deal with this. At the time, we had really one. So there is clinical data from Roxana Moran that showed that performing laser atherectomy in combination with PTCA provided a better luminal gain at the expense of the intimal hyperplasia for patients who had in-stent restenosis. This is data from 1997, but I think it's still relevant today because for the majority of our in-stent restenosis patients, we're performing laser atherectomy, especially and usually for intimal hyperplasia, in order to modify the layers of scar tissue within the stent, but more importantly, what's outside the stent and more difficult to treat. So we went ahead and performed laser atherectomy of the entire RCA. Usually we say that the vapor bubble of the laser catheter is going to double the size of the catheter. So we used a 0.9 millimeter catheter because there were areas of 1.5 to 2 millimeter stent that we were trying to modify. Deliverability back to Elias as part of the talk, guide catheter size, guide extension utilization, getting the support to get through all this is very important. So used a 0.9 millimeter catheter at 80/80, so the maximal output, all the way down through the vessel, and then perform PTCA of the vessel with a 1-to-1 sized scoring balloon all the way back, and then perform brachytherapy. Distally gave 18 gray, proximally gave 23 gray. And this gentleman's case was done almost a year ago at this point, and from a guy who had been coming in recurrently with angina and having issues over and over again, he's been able to get back to work and do the things he needs to do and live without fear of at least his coronary disease. I don't know about the prisoners. So calcium modification, last topic we'll talk about tonight. You can't talk about complex coronary disease without figuring out how we deal with these calcified patients. One of the things that we look at in JCTO and risk calculations for these patients as well. Historically, orbital and rotational atherectomy have been the mainstays of treatment. Laser atherectomy before that. Really, laser is limited to mild or even moderate calcification. The CSI device proved to be easier to use until the advent of the newer version of the rotablator from Boston Scientific, which is also now used frequently by many institutions. And all of the controls are on the console. You still need gas for the rotablator. You use electricity for the CSI. And then approved early last year for commercial use in the coronaries, we now have access to lithotripsy. All of these tools have been used with great success in several complex coronary cases. There's a publication in process right now looking at the use of IVL in CTO from Progress CTO as well that hopefully will shed some light on that. So looking at a patient who had a couple of these modalities used, 78-year-old gentleman with a history of bypass. His left radial had been used for bypass, which is why we're growing. I apologize to those of you who are biradialists to see that there. Had demonstrable ischemia and viability on his MRI, on 4 antianginal, still having chest pain. So came in for RCA, CTO, PCI, had a history of stenting of that proximal right as well. We thought initially that there was going to be a microchannel that would connect all the way to the distal vessel. But as Elias showed in a previous case, sometimes the best microchannels are bridging collaterals or non-existent at all. So started with a turnpike spiral, went antegrade with a hydrophilic jacketed non-tapered wire, quickly became subintimal. So looked at the left main, there weren't any retrograde options from there. His retrograde filling of this vessel all came from that radial graft through epicardial collaterals. So microcatheter stalled out about there, even though we had a little bit more in the way of support. So performed balloon angioplasty with a 1.5 and then a 2.0 Terumo in an attempt to break the calcium and previously place stents. There is a technique called balloon-assisted microdissection, or BAM, where you actually explode the balloon on purpose in these vessels. We sometimes inadvertently do that as well because balloons tend to rupture. So we have a wire down. We were unable to get the microcatheter to pass where we were. So at this point in the CTO algorithm, you have a wire across gear won't go pathway to work through, which includes the use of laser atherectomy. So used a laser, 0.9 laser, making sure that you're coaxial on the cap, that you're not pointed at the sidewall. And we use this in order to try to soften the cap to allow for passage of our equipment. This was unsuccessful as well with regards to our ability to pass through. Ignore the tip of a hydrophilic jacketed wire that's there that wasn't there before. But we were able to advance a little bit further over a new wire. And then advanced a 2.040 balloon into the distal vessel and performed angioplasty in the subintimal space. We were approaching our radiation limits. We set 5 gray as our limits for radiation unless we're pending completion or we're in a position where we've caused a complication and we really need to continue for patient safety. So balloon the vessel and then defer further intervention once we get some antegrade flow into the vessel distally, which you can see through that dissection flap. So this has been studied with regards to what factors will increase the likelihood of us having successful CTO PCI after subintimal or extra plaque modification. And the factor that came to be most significant with regards to failed attempts is if you come back within 60 days, that decreases your chances of getting this done successfully. So by routine, we'll wait 61 days or longer, but not too much longer than that, and bring the patients back. So came back in 2 months or so after the index procedure. On injection, had healed dissection flaps with antegrade and retrograde flow. Again, we got stuck in the mid-vessel. So in this case, we advanced the microcatheter as far as possible and then swapped our wire for a rotofloppy wire and performed rotational atherectomy of the proximal and mid-vessel to break up the old stents and the calcium. Yay, rota. And then that allowed us to get down to the distal vessel with a knuckled hydrophilic jacketed wire, and then ended up having to, again, perform subintimal tracking and reentry because of their inability to get things to reenter distally and get the balloons to the distal vessel. So again, we performed balloon angioplasty all the way back. We performed intravascular imaging, which let us 1-to-1 size the balloon to the vessel itself to make sure that we were fully modifying the plaque. We decided to stent the proximal and mid-vessel to improve the outflow. So balloon tracked the trap liner. I guess I'm the bat guy here for this. Could have inchwormed it, I guess. But the balloon tracked to the distal vessel to allow for stent delivery, and then stented the proximal and mid. We know that from early trials in STAR, subintimal tracking and reentry, that stenting the distal vessel leads to poor outcomes. So we try to avoid that whenever possible. So we're currently in the phase where he's going to come back and have his procedure completed. We're in that 2-month holding period for that 60 days for him to get cleaned up. So last case, I think, for the evening on our standpoint, and then we'll take questions on anything in the world. Elias will tell you that we're nothing if not opinionated, especially me. So 78-year-old gentleman, history of RCA PCI, found to have a subtotal occlusion of his RCA, had scar with viability and 3 antianginals with ongoing symptoms, so came forward for PCI. And as we all know, underexpanded stents are terrible. So easily wired the vessel, performed balloon angioplasty with high pressure NC balloons in the US. We don't have OPN, so we're limited to what's on the shelf. Unfortunately, we had several segments of stent under expansion. So we performed laser atherectomy of the length of the sentence segment, and may have done some things that are off-label with that laser atherectomy as well that we won't talk about tonight. Came back in with NC balloon size 1:1, and high pressure could not get that stent to expand. So at that point, we have a couple of options. One is to go in with ROTA and try to break the stent struts that are causing the issue, and then re-stent. The patient already had several layers of stent, and adding a fourth or fifth layer did not seem like an attractive option. And then nowadays we have the option to use intravascular lithotripsy. So ended up going in with a lithotripsy. There was calcium deep to both layers of stent here, and went to 4 atmospheres, delivered all of our pulses throughout the vessel, and got some improvement, but again, nothing is a panacea, especially in multi-layer ISR. So unfortunately, the patient's done well overall, and the plan is, if he has recurrent restenosis, to proceed with either rotational atherectomy to break the stent struts, or refer for bypass of his right coronary, which we hate to do for non-LAD vessels given the lack of mortality. But if necessary, we can do that. Unfortunately, he had new stents within 6 months, I think, in the proximal vessel, so brachytherapy has been deferred. We usually wait a year after that. So with that, I think a whirlwind of cases that we have presented with regards to CTO techniques, complex coronary techniques, how to build a program, how to get those around you to buy in. And we have a great team at St. Thomas, from our coordinator to the nurses and technicians, our anesthesia team that works with us, and the administrative support to make this all happen. And again, I know Elias started the talk with a thank you to Eric and Amy and Josh and Hillary and everybody who's here. Good to see some of you in person again for the first time in years, and some of you since CTO Summit a couple weeks ago. But we're now open for questions about anything. So please feel free.